Hello folks, I'm Matthew Luedke. I'm the Medical Director of the Neurology Consultation Services here at Duke University Hospital, and it's my privilege to be with you. Today we're going to be talking about brain death and the assessment of cessation of cerebral function. So today we have several goals. First, we're going to understand the legal context of the determination of brain death, particularly in the state of North Carolina. We're going to take a brief tour through the general pathophysiology of brain death. We're going to learn about processes for assessing cessation of cerebral function. And then finally, we're going to end with understanding options for confirmatory testing and which ones you might choose and why. So for basic premises, all death is brain death. Life experience is a product of cerebral function. And if your brain stops working, you stop experiencing life. If your brain stops working permanently with no expectation of recovery, you will no longer have any life experiences, and in essence, you are dead. Again, functionally, permanent loss of cerebral function is death. Now it depends on how you get there. You can get there conventionally through cardiopulmonary arrest, where you lose cerebral perfusion. Alternatively, you can suffer a catastrophic brain injury. But regardless, the final common pathway of this demise isn't cessation of cardiopulmonary function. It is the death of brain tissue and the cessation of experience. So, from here on out, let's think about the fact that all death is brain death. With that in mind, let's talk about a history of brain death. So brain death, as we understand it, is actually a product of 20th century medical advances. Certainly people died of brain injury prior to the 20th century. But when the brain was irreversibly damaged, the patient underwent eventually cardiopulmonary failure and was pronounced dead in the conventional manner. Either that or it was so obvious that the injury was non-survivable that it was considered a sign incompatible with life and they were pronounced. But with the advent of successful and prolonged ventilation, initially in the 1920s with the iron lung, and later and more pertinently in the 1940s and 50s, you had patients who were in coma for a sustained period of time and were not getting better but weren't dying because we were breathing for them. In the literature, this sustained irreversible coma was described in the 1950s by Wertheimer et al. It was described as death of the nervous system. Pima-Larey et al. Also described it as coma de passé. In the United States, Plum and Posner's diagnosis of stupor and coma became a treatise on this general subject. In 1963, these concepts of irreversible cerebral dysfunction and coma de passé led to the first beating heart, brain-dead donor transplant surgery, a kidney transplant. Again, in the United States, in the 1960s, we had our first description of an irreversible coma by the Ad Hoc Committee of the Harvard Medical School. This was published in JAMA in 1968. In 1978, in an attempt to come up with a uniform set of standards that state laws could create to address this issue of death by brain criteria, they came up with the Uniform Brain Death Act. Now, there was a problem with this, and it discounted the concept, or at least it neglected to mention the concept of standard cardiopulmonary definitions of death. So, with the assistance of the AMA, the ABA, and the President's Commission for the Study of Ethical Problems in Medicine and Biomedical Research, a new version of this was created in '81 called the Uniform Determination of Death Act, or the UDDA. And this remains the standard for which state laws are written on the issue of brain death. Despite the Uniform Determination of Death Act resolving a lot of the conflicts in brain death law, there are current and future issues that continue to arise. One major issue is the expansion of ECMO, extracorporeal membrane oxygenation. Other issues include ongoing legal challenges to brain death cases, the most famous recent one being the Jahi McMath case in California. And finally, issues with uniform application of brain death techniques. So let's look at the pertinent statutes in North Carolina governing brain death. The North Carolina General Statute 90-323, death determination by a physician, dictates that the determination that a person is dead shall be made by a physician licensed to practice medicine, applying ordinary and accepted standards of medical practice. Brain death, defined as irreversible cessation of total brain function, may be used as the sole basis for determining that a patient has died, particularly when brain death occurs in the presence of artificially maintained respiratory or circulatory functions. This recognition of brain death as a criteria of death of the person shall not preclude the use of other medically recognized criteria for determining whether and when a patient has died. So let's unpack this. First, the person to determine death must be a licensed physician. It doesn't need to specifically be a neurologist, although some hospitals do have that policy, but it must be a licensed physician. It must be determined that there is cessation of whole brain, total brain function. That means both brain and brain stem. And this dysfunction can be the sole criteria that a person has died, which means that after you do a brain death assessment and necessary confirmatory studies, that patient is dead. You need no further workup. You don't need to have the heart stop. You don't need anything else. You can declare them at that point. Now, it asks that you use accepted medical standards and practices. For neurologists, this refers to the AAN 2010 guidelines. Now, this is a published guideline that everyone can access and use and suffices for these standards. Hospitals like Duke have their own specific set of guidelines which are built off of that and are also acceptable. Now, one last thing to consider, and it's important, you can diagnose someone as dead by brain criteria, but this still allows for the diagnosis of death by other criteria, such as cardiopulmonary criteria. The law aside, let's talk about pathophysiology. In broad strokes, the pathophysiology of brain death is a fairly stepwise process. It requires a catastrophic brain injury, or CBI, and you can proceed to mechanical ventilation to support the life of the person who is no longer able to protect their airway or initiate respirations. Or conversely, someone who's on a ventilator can then suffer catastrophic brain injury. Regardless of that order, you then proceed to continuing deterioration and progressive loss of brain functions despite intervention. N1. Now this N1 state, as it is conceived, you can potentially at least arrest or maybe reverse. If you continue to have worsening cerebral function, you will have cessation of brain function. This is a deep coma, GCSs of 3. And at this point in time, in principle, according to this conception, you might still be able to at least halt or maybe reverse the dysfunction. But if you progress further, you will get to a state where no matter what interventions you do, no matter what changes you make, there is no going back and the brain will no longer ever recover. And this is brain death. Now, independent of brain death, or at least in concert with it, there is the concept of cardiopulmonary death. You can approach cardiopulmonary death from either two perspectives. One, someone who's receiving CPR but not improving, or two, someone who is not receiving CPR, whether they pass away in the field, or whether they're arresting in-house, but they are DNAR. This is a little bit easier to understand and conceptualize and is practically a little bit more commonly seen. C1 is a cessation of circulation and breathing, where the patient might spontaneously recover. This is the person who goes into prolonged runs of VFib but pops out, or VTAC but pops out. You can still resuscitate them, but they could potentially resuscitate themselves. C2 is the cessation of breathing and circulation with no possibility of spontaneous recovery, but who's potentially reversible with CPR. If this goes on long enough, of course, then you'll have cessation of breathing and respiratory or circulatory function with no hope of recovery. And then you're dead. If you sandwich the two together, they generally function pretty well in concert. If you have circulatory arrest leading to death, you have cessation of breathing and circulatory function, and by that time, with no blood perfusion, you're already in a state of N2, total cerebral inactivity. If that continues on long enough, that cerebral inactivity becomes permanent injury and becomes irreversible, and that likelihood of progression to N3 continues and worsens as you go to C2 and then eventually C3. By the time you get to a point where you have no hope of circulatory recovery, you also have no hope of neurologic recovery. Now that we've talked about the physiology of brain death, at least in broad strokes, let's talk about the cost of misdiagnosing brain death. So the declaration of death by CNS criteria is frequently followed by organ donation. This is both a good and a bad thing. It's a good thing because the opportunity to describe someone and diagnose someone as having irreversible cerebral dysfunction while their heart is still beating allows for the opportunity of more viable organs to be removed and transplanted into patients who need them. It's bad because, at least in the community, there is a perceived conflict of interest. There is a sense, if you look at the media and if you look at conversations among patient websites and such, that doctors want to diagnose people as brain dead so they can get body parts. Now, while this is not really in practice, at least as physicians conceive of it, there is no small pressure in a patient who is terminally ill with bad neurologic function to assess for brain death. So you have to approach it very carefully. We have to make sure that there is no conflict of interest. Also, another consideration is organ retrieval in these patients is performed without anesthesia. If you are wrong about the diagnosis of brain death, particularly if you have a brain death mimic, such as Guillain-Barré, where you have dedifferentiation and no motor function, but you still have intact consciousness, this presents a horrifying possibility that a patient could go to surgery without anesthesia. Now, this horror story scenario aside, misdiagnosing brain death can also lead to problems on the organ donation side. If you don't timely and accurately diagnose a patient who is brain dead as brain dead, they may become hemodynamically unstable and they become poor organ candidates if they undergo cardiopulmonary dysfunction and death as well. You don't want to diagnose too early and wrong. You don't want to diagnose too late. It's a balance. Now let's get to the meat of this lecture and talk about determining cessation of cerebral function. The first step of approaching a brain death assessment is establish the presence of coma and the proximate cause. You need to assess the patient and identify a GCS of 3, and you need to find out why they have that GCS of 3. There needs to be an identifiable catastrophic brain injury by history and by imaging. What does this mean? If a patient had anoxia from a cardiopulmonary arrest, if the patient had a severe head injury, and then you can corroborate that with imaging findings consistent with diffuse cerebral edema, laminar necrosis, hemorrhage, then you're fine. But if you have a vague history and you don't know why the patient is comatose, or you do imaging and the brain is entirely intact, you cannot proceed with the determination of brain death. You need to be very watchful of mimics in these situations. Things like organophosphate poisoning, Guillain-Barré syndrome, even high cervical injuries can appear much like brain death if you're not wary. So again, I can't emphasize this enough. Always be aware of the cause of coma and be able to identify a critical catastrophic brain injury before you proceed. Once you've established coma and the CBI that caused it, Then you can proceed with the examination. But before you do the examination, you need to sort of be a cook. You need to have your mise en place. The stage needs to be set. You need a patient who has a body core temperature of greater than 36 degrees Celsius. There's an old saying, you ain't dead until you're warm and dead. And we need the patient warm to determine if they're dead. If they've received any sedating medications, the recommendation is that you wait at least 5 half-lives for sedating drugs to get out of your system. And if available, check levels. This is particularly pertinent to barbiturates, where the only acceptable level in your system is below 10 micrograms per milliliter before you progress with a brain death assessment. If the patient's had any recent neuromuscular blockade, you need to demonstrate that it's been processed and excreted from the system. And you do that by taking a train of 4, which needs to be fully intact. You need to address gross metabolic and endocrine derangements. No horrible blood sugars, no hyponatremia, no bad uremia, no hyperammonemia. Get the patient as metabolically cleaned up as you possibly can. This can be a very difficult one coming up next, but target systolic blood pressures of equal to or greater than 100 millimeters of mercury. At that level, brain function is presumed to be adequately supplied by blood. Below that level, you're iffy. And finally, the patient's going to be on an vent. Make sure that their vent is showing no spontaneous respirations. Once that's all set up, you can proceed on with your exam. Now your exam is mostly a brainstem exam with a little motor thrown in at the end. You start off with a pupillary assessment. You want to see midpointer dilated, non-reactive pupils. If you note pinpoint pupils, you should be suspicious for the possibility of ongoing activity of sedating medications in the system. It's not a game breaker, but it's something worth considering. Next, you want to assess corneal reflexes. They should be absent. Corneal reflexes are best checked either with a cotton swab or with saline drops. The common preference nowadays is saline drops because cotton swabs can injure the cornea, which is a transplantable organ. Oculocephalic reflexes must be absent as assessed by cold calorics. And the way you test them is you set the patient at 30 degrees and you take 50 or more milliliters of cold water and slowly flush it into the ear canal. You need to watch for 1 minute after completing the flush, and then you repeat on the other side after a several-minute interval. Again, you have to observe the eyes for 1 minute because the cold caloric response can take a while to kick in. No facial movements on noxious stimulation is the second thing you check, or next thing you check. It's important to note that for this test you need to use either supraorbital notch pain or temporomandibular joint pain to assess. Supraorbital notch is found on the ridge of your eyebrow, and it's a small divot that you see right about in the middle. And if you push there on yourself, you'll note that it's pretty uncomfortable. Likewise, the temporomandibular joint is right there anterior to the ear. Pressure on either of those places is considered sufficient and proximal enough to be reliable, even in a comatose patient. One other note, a lot of these patients don't have complete eye closure and have poor facial tone. That means that people are using Lacrolube to keep their eyes moist. Lacrolube makes your supraorbital notch region pretty slippery. Be careful if you stimulate there. Enucleating a patient during a brain death exam is considered very tacky. Next, you want to check gag reflex. We use generally those sponges that you use to swab out the mouth and give moisture to patients who have a dry mouth. That works pretty adequately and it doesn't injure the soft palate. Cough reflex needs to be assessed with deep tracheal suction. Get that thing down to the carina. Finally, you want to check motor response to noxious stimulus. This means that if you apply nail bed pressure or a strong pinch to all 4 extremities, there will be no withdrawal or no purposeful response to that. That does not mean there will be no movement. There are numerous tolerable reflex movements that you can see with noxious stimuli in brain-dead patients, but the emphasis is these are reflex movements. They can range from twitching of the fingers to triple flexion, which is the flexion of the foot, the knee, and the hip, or outright Lazarus sign, where the patient flings the arms forward and they cross over the chest. But these are all spinal cord reflexes. There is no purpose to them. It's not a response to pain per se. It is just a reflex arc, and it's all extracranial. After you've completed the cranial nerve exam and assessed for peripheral motor function, the final component of the brain death exam is apnea testing. Apnea testing assesses if there is any intact respiratory drive and represents the final proverbial nail in the coffin of a brain death diagnosis. To do it, the patient must be hemodynamically stable. You need to adjust ventilator settings for normocarbia, targeting, if possible, a PaCO2 between 34 and 45. You need to pre-oxygenate the patient with 100% FiO2 air for greater than 10 minutes, and you want to target PaO2 of greater than 200 millimeters of mercury. The patient should be, during this time, set at a PEEP of 5 centimeters of H2O. When you've decided that it's time to perform the test, you need to oxygenate the patient. You have two options. You can either take a suction tip catheter, place it through the endotracheal tube at the carina, and run it at 6 liters per minute, or you can take a T-piece, place it to the end of the endotracheal tube, and set the patient on CPAP at 10 centimeters of water. Then you disconnect the vent. After you disconnect the vent, your job is to watch carefully for any evidence of spontaneous respirations. You can do this by looking at the chest wall, using inline manometry, or even using end-tidal CO2. Regardless, if there's any evidence of respiratory effort, the patient is not brain dead, and you have to discontinue the test. However, if there is no evidence of respiratory effort, you continue monitoring for 8 to 10 minutes, after which time you obtain an ABG. If the PCO2 is greater than 60 millimeters of mercury, or if there is a change from baseline of greater than 20 millimeters of mercury, and again, if there was no respiratory effort, then the patient is dead. Time of death in these cases is the time of the last ABG at the end of the apnea test, confirming either PCO2. Time of death in these cases is documented as the time of the last ABG checked during the apnea test. Now, there is a potential that an apnea test must be aborted or is ambiguous. The apnea test must be aborted if there's any evidence of hemodynamic instability or oxygen desaturations during the test. Alternatively, if the PCO2 does not rise sufficiently or does not hit 60 millimeters of mercury, then the test is inconclusive. A brief note on ECMO and the apnea test. Needless to say, if you are oxygenating the patient for them, they have no need for a respiratory drive. So you need to have some form of provocation to get the brainstem moving air. There's no consensus protocol for apnea testing. There are some published protocols, of which I will cite one, but again, this is just an example, and a typical one. In this example, you use CPAP with an inline manometry or end-tidal CO2. You want an FiO2 of 100%, and you want to set the gas sweep to the lowest level possible to ensure at minimum 90% O2 saturations, and keep it there for 8 minutes. Then you bleed in CO2 to the oxygenator to a target PCO2 of 60 millimeters of mercury or a change of 20 millimeters of mercury. As you do this, you watch for respiratory effort. And if after 8 minutes at this target there is no respiratory effort, you do an ABG to confirm the gas changes one more time. And if that comes back confirmatory of a PCO2 of 60 millimeters of mercury, or again a 20 millimeter of mercury increase from baseline, then the patient is dead. Finally, let's talk about ancillary testing. Ancillary testing should only be considered and is only necessary if a clinical exam cannot be fully performed or if the apnea testing was inconclusive or aborted. Now, what would be an incomplete clinical exam? Now, it's not a clinical exam where there were some positive findings and some negative findings. For example, if you have a pupillary response or you have a corneal response, that is not an incomplete exam. That is a negative brain death assessment. The patient is still, by definition, alive. Rather, it's if one of your tests is inhibited by the patient's anatomy and physiology. For example, if your patient had a traumatic brain injury and had a basilar skull fracture, you don't want to perform oculocephalic testing by inserting water into the ear canal, which could then enter into the skull base. That would be considered tacky, even if the patient were brain dead. Alternatively, a facial injury could cause bilateral enucleation, and you can't assess pupillary function, corneal responses, or oculocephalics in an enucleated patient when it happens bilaterally. So there may be times when you can't complete a full clinical exam on these patients. Likewise, again, if the patient became hemodynamically unstable and you couldn't perform an apnea test fully, or if they desaturated during the test, regardless of whether they had respiratory effort or not, you couldn't complete the full test and you need a confirmatory modality. There are 4 validated ancillary testing modalities, and they are the conventional cerebral angiogram, cerebral scintigraphy, EEG, and TCD. Each has their advantages and disadvantages. Conventional cerebral angiogram is an expensive procedure, it's a time-consuming procedure, and in general, proceduralists don't like doing it on people who are dead. That said, it's very replicable, and if you see no cerebral perfusion on the study, that is a perfect confirmation of brain death with a high sensitivity and specificity. Another alternative is cerebral scintigraphy. What you do is you insert a radiotracer into the blood and look at its uptake in the brain. Again, if you see no evidence of cerebral perfusion, that is a good confirmation of brain death. EEG is different. EEG looks at physiology and not blood flow or anatomy. If you order an EEG for a brain death assessment, you must notify the provider that you are doing it for a brain death exam because they need to meet certain criteria when they do the study for it to be sufficient to assess for brain death. You are looking for electrocerebral inactivity as assessed at 2 microvolts per millimeter sensitivity. Sometimes if the patient is in an electrically unsound environment where there's a lot of artifact on the EEG, it might not be helpful. TCDs is the final modality. It uses ultrasound probes to blindly insonate cerebral blood vessels to check for flow. It's best used on patients where you've had the expectation that there will be a progression to brain death and you've gotten the baseline study where you can assess the presence of detectable vessels in the skull. Some patients' anatomy is not amenable to TCDs, and it's hard to differentiate that from someone who has no cerebral blood flow. So you want to check on these patients before they're dead to see if you can get any signal from their cerebral blood vessels. If you can, and then you do it subsequently after the brain death assessment, and there is a change or there is no flow, then it becomes a reliable study. However, if you have no baseline and if you can't detect any cerebral blood flow on the study, you don't know if that's just because their skull doesn't let the signal through. Each institution has access to different variants of these studies. It's up to you and your colleagues to determine which ones are the best in your institution. At Duke, we're lucky and we have the availability of all 4 of these studies, and I've seen all of them used. So, let's review. All death in the end is brain death. The law necessitates a cessation of brain and brainstem function to determine brain death. Cessation of cerebral function requires an identifiable catastrophic brain injury, an amenable physiologic state to perform the exam, a careful and systematic exam, and an apnea test with special considerations if the patient is on ECMO. You can use confirmatory testing if the exam can't be completed or if the apnea testing is inconclusive or ambiguous. And if all of that's the case, then you can finally diagnose the patient as dead by cerebral criteria. Here are my references. I appreciate your time and consideration, and thank you for the opportunity to speak to you. A little bit of a disaster there on occasion, but